back to our continuing conversation of the basics of the anemias. It is almost 3 a.m., but we are awake, barely, I think. But we're going to continue talking. We were talking about blood loss, some basic features of all anemias, acute, chronic blood loss. We talked about impaired production, aplastic anemias, pure red blood cell aplasia, renal failure, defective DNA synthesis, which is megaloblastic, defective heme synthesis affecting iron carrying ability, and deficient globin synthesis, which is these are the thalassemias. Anyway, moving on, we should be talking now about the basics of the modifiers. So MCV, we're talking about the mean cell volume. What is, microcytosis? This is when you have small red cells. How about macrocytosis, large red cells? So we have MCH. Remember the MCHC? That was the mean cell hemoglobin concentration. And these are hypochromic. And how about RDW? What should we be thinking about that? Remember that explanation? RDW? Anisocytosis, which is a variation in size. So let's start and talk about our first real type of anemia, and this is microcytic anemia. So what comes to mind when you think about microcytic anemias? Well, you should first think of iron deficiency. It's an iron deficiency anemia. And what would you expect the serum iron to be in this situation? The serum iron would be low. What is transferrin and TIBC? Well, transferrin would be high. The liver produces more transferrin, presumably attempting to maximize the use of the little iron that is available. And what is transferrin? This is what brings the iron into the cell, into the liver. Wait a minute, I'm getting confused here. What I want to say is that transferrin is a plasma protein that transports iron through the blood to the liver, spleen, and bone marrow. And the blood transferrin level is tested to determine the cause of anemia, to examine the iron metabolism, for example, and to determine the iron carrying capacity of the blood. And remember that the liver produces transferrin, and when the serum iron is low, it increases the level to try and compensate, to try and maximize everything that's going in, but it's kind of spinning its wheels. It's not really working very well. It just, that's what you would find. Anyway, how about the percent of the transferrin saturation? Remember, this would be low because there is insufficient iron. So what is TIBC? This is the total iron binding capacity. And this is a test which measures the blood's capacity to bind iron with transferrin. So with microcytic anemia, you should think about transferrin and TIBC, low serum iron levels. Okay, and on to the basics of the thalassemias. We've looked at thalassemias before and studied them in detail, but just remember what this is involving. What is this involving? Synthesis of what? It's involving the synthesis of globin, the alpha and beta chains. And what type of disease is this? Well, it's a genetic disease, but is it recessive or dominant? It's recessive, so you'd need two alleles. So remember the alpha and beta chains, and deficient synthesis is involved here. These are often termed major or minor depending on the severity. So remember that there are silent carriers, and because this is a recessive trait. And what are some of the major features here of the thalassemias? Well, one is hemolysis. Another one would be microcytic anemia. For example, the low mean cell volume, low MCV, which is just like an iron deficiency anemia. And when you're looking at a skull, what would you see? A skull x-ray. You would see a crew cut appearance, which may be seen in severe erythroid hyperplasia or bone marrow expansion, because there is some compensation here as the body tries to fill up with bone marrow.